Good evening, everyone. Happy Wednesday. I always appreciate that people get on here live. I'm sure many of you have had a long day like I have in pediatric dentistry. And as you know, pediatric dentistry can be tiring, especially when you need to sit in class for a little bit. So I do want to thank everybody for being here tonight. You know, the goal of these mastering webinars are to help those of you that already have these devices. Now, some of you, and we'll do a poll here in just a minute or in a few minutes, but some of you are new and that's fine. But I always encourage everyone to not only watch this webinar, but previous versions as well. We typically will add on content, we'll change content every single time. And it is recorded and you'll get all your CE units. If you have questions, feel free to put them in the chat. Sometimes if it's something that's really pressing, they'll interrupt me, which is absolutely fine. But at the end, we're going to have plenty of time for questions. The other thing is you're going to get my contact information. So I try to be as reachable as possible. Usually I'm on the phone or texting at least one of you guys or two of you a week. And so you'll have access to me at any time. And hopefully if I don't have the answers, I will kick it up the line and get you the answers. So again, let's get rolling. So thank you so much for being here tonight. The point of this webinar is really to understand in detail and really become a master of intraosseous delivery of local anesthetic for a pediatric patient. I can tell you that this has completely changed the way that I do so much in my office. Case in point, today, I had a patient that, 5-year-old, very nervous, needed a couple extractions, and that child would have 100% been scheduled for oral conscious sedation before I started using these devices. And got him in the chair today, nitrous, put a movie on. He did not feel a thing when I took out S&T that were abscessed. Mom was amazed. I'm still amazed after doing this for, 9 months to a year. And I can tell you that I have not picked up a standard syringe to administer local for a patient under 14 since I've gotten these devices, not once, right? There are times, and we'll talk about this for older patients, that it may not work, but this has completely transformed the way that I deliver local anesthesia in my office. It's given me the ability to not do anywhere as close to the amount of sedation anesthesia I was doing before, general anesthesia was doing before. And as a practice builder, there is nothing better than having a parent who's convinced that their child's going to cry and have a tough time, and they have an easy appointment. It doesn't get better than that as a provider of care to not be the one that's causing that emotional trauma to your child. We get used to crying, but if we don't have to have it in our practices, that's great. So thank you so much again for being here tonight. So this is the mastering webinar. And as I said, we do these every single month. We also pair these webinars with the introductory webinar. And so Ann Bynum, who is one of my teaching partners, she is amazing. Clinician and practice management expert, and she's going to be teaching most of the introductory courses. We will flip-flop, and then next month I'm super happy to announce that Dr. Paul Bond, close friend and an unbelievable clinician and educator, he's going to be teaching the mastering course next month. And then we have Dr. Megan and Dr. Miranda that teaches this as well. So one of the ways that I learned how to use these units is I would just listen to the webinars literally on the way to work and coming home. And I was still paying attention driving, I promise. But I find in order to be an expert on something, it's not only understanding how to use these devices, but it's understanding the lexicon, right? Understanding the difference between osteocentral local anesthetic and giving intraceptal local anesthetic, just terms like this. The more that you're educated in the procedure, the more you're going to feel comfortable, the more you can talk to colleagues about it, the more you can talk to parents about it. So I really do encourage all of you to not only listen to the webinar tonight, but listen to these ones going forward. And we will be switching, some of the instructors around so you see some new material and new faces. Just a little bit about me. I am a pediatric dentist, like most of you that are on here tonight. I've been in practice now for 22 years. I had things pretty easy. I took over the practice from my father, so I'm second generation, and then built up the practice. I'm a diplomat of the board and a fellow. I spend probably about 70% of my time here in the office, and the other 50% of my time is the joke in education. So doing webinars like this. I also own and run the BioClear Pediatric Learning Center here in Livermore, California. And my practice, where I spend majority of my time, it's myself and another associate. About a year and a half ago, we moved into the new center. I was really able to build the practice of my dreams and then integrate a learning center into that. And so I think this year we're doing 15 courses or so, both here in office, doing some online. Besides dentistry, I like dentistry. My wife doesn't like that joke either, but she wanted me to get a hobby that didn't involve seeing patients, and I picked teaching about dentistry about, I don't know, 12 years ago. And again, I find that funny. She doesn't. But along with teaching restorative and teaching local anesthesia, I really enjoy learning and teaching accounting and financial analysis for dental practice and photography. And also one of the things I won't talk about tonight, but using enhanced magnification. I really believe to do the best work possible that you really need to be able to see. So if you come train with me, that's something that we talk about. And there's the new facility and some photos we take. The theme I went with the office, just open and bright. I wanted a lot of primary colors. I wanted everything really to be clean. I didn't necessarily want to go with a theme. And we've been in this facility now about a year and a half. So we're in about 6,000 square feet along with the learning center. And when we don't have patients, we have courses, we shut down the practice. It's all integrated in together. And so when we teach courses, we're all in, 2 rooms, either in the classroom or we convert the operatories into teaching centers like this. So some of the rooms have microscopes. Some of the rooms are set up like this and, different configurations. But everything's small group, hands-on, really learn restorative in a small group. In an atmosphere, there's only about 13 of us at a time. So I try to keep the doctor-student ratio down very low. And there's microscopes. And this is some of the material that I teach, along with, teaching NuSmile products and zirconia crowns and BioFlex. We teach a lot of just hands-on composite. We actually have matrices that are shaped like the teeth. And you can definitely do beautiful work if you have a matrix that's shaped like the tooth. So that's my learning center website there, pediatricdds.com. But tonight, we are going to be talking about something that I'm extremely passionate about, as passionate about as teaching restorative, and that's local anesthesia. As I mentioned, I am very reachable. If you reach out to me, if you email me or you text me, if you scan the QR code there, you'll get all my contact information. I promise I will get back to you. If you text me and you need something immediately, please tell me it's urgent. Or if you send me a message and I don't get back to you in a day or two, please follow up and let me know, hey, I reached out to you and you didn't call me back. I do travel to speak and have practice, but I do try to get back to people as soon as I can. And that's my bunny Charlotte down there and my family. All right, so to get started here, it's nice to know the breakdown of the group. So I'm going to go ahead and let Jordan take over here. And Jordan, you want to talk about our poll?
Yeah. So just went ahead and launched it. Y'all should see that popping up. So 3 questions. Please answer. So which device you own, SOAN Sleeper 1, or you don't own one. And then the second question is, who's using these devices exclusively? We'll see some answers there. Then the third question is, what is your delivery method preference? So if you own the device, knowing that it's in cruise mode or drive mode, or you're not exactly sure, but the difference is cruise mode, meaning you press on one pedal to start it, and then you press on it again to stop it. Drive mode, meaning you're pressing and holding to deliver, and then you'll let go to quit delivering. So drive mode is standard on all Sleeper 1 units, and then for the SOAN, it can be either or. So please go ahead and answer those questions. So we'll give this another minute or so. Looks like there's still some more answers coming in.
Jordan, while these answers are coming in, do you find that most doctors leave their set for their SOAN on drive or on cruise?
Yeah, that's a That's kind of like a hot debate I get, or I get asked
Correct.
on all the onboardings. So what does everyone else do? And honestly, it's really split. So these days, the SOAN comes standard on what's known as cruise mode. Um, a lot of doctors will just leave it. They get used to it and they like it, and that's fine. A lot of times, doctors will have watched, one of Larry's older webinars, and she really advocates for, switching over to drive mode as you start out. Um, so it kind of depends, really, if they feel like, messing with the settings and doing that, or if they want me to walk through them. But I'd say it's pretty split for sure.
Okay. And we're going to be going over that tonight, the two different modes and how to change those. Okay.
Awesome. So I think we're just about good on the poll here. I'll go ahead and end that. So it looks like, good majority of everyone owns the SOAN or is not an owner yet. So, and then when it comes to the second question, really kind of split. But again, either not owning it or they use it themselves on just about all of their patients. Sometimes they'll go back to a traditional syringe or depending on patient age. And then it looks like um, majority are using it in drive as compared to cruise. Um, and then quite a few aren't sure exactly which they're in. So
We will answer that for you tonight. And tell me again on the first question, what percentage of docs actually own a unit right now versus don't own one and are new? Are you able to?
um, yeah, so half of those who answered own the SOAN.
Okay.
And then one in here owns the Sleeper One. And
Nice.
so about 47% do not own a
Got it.
unit yet.
Okay. So for those of you that don't own a unit yet, we're not going to spend a ton of time going over the basics of these. That's where I want you to, tune in to Ann on our next webinar, look at any of the previous ones, and that's going to give you all the basic background information. We're going to go through a little bit of that, but really tonight and on these mastering webinars, we want to give you as much up-to-date information as possible so you feel like if you already have some baseline knowledge of these units, that by the end of this, you really are starting to feel like you understand everything in detail. So great. Okay. Thank you. Thank you. So quick history. I started with NuSmile products actually way over here. I'm showing my age a little bit, and they only had signature crowns. And I trained actually at University of Texas, Houston. So NuSmile is right down the street. And I've seen this just amazing development of products. And these are all things that I use on a daily basis in my office. Bioflex crowns I got, I think, right when they came out, and I've been placing a ton of them. I love these universal chairside space maintainers, especially when I have children that have space loss, because the products I was using before, I was having to cut tubes and it just never worked out well. And it's nice to keep the inventory lower. And I will tell you, when they say more to come, there really is more to come. They're constantly looking at what materials, what methodology can they bring to pediatric dentistry. And, the SOAN and the Sleeper One, we're late to the game, right? Most other countries have had these units. We talk about this in the intro. Have had these units for 10 years, 15 years, and it was not until NuSmile saw these really at a show and put all the money and time and going through FDA clearance, because trust me, it's a lot of work and money that they brought these to us. So I'm very grateful that we have these units, because I really would not want to practice pediatric dentistry without it. I just want to show everyone and point out some people that really are amazing educators. And all of the people that you see here are doctors that will give you the time that you need. I saw Sarah, you're tuned in there earlier. And really, if I don't have the answer, someone here on this map does. And all of the doctors that I've worked with NuSmile, they're all educators. All they care about is making sure that you guys have the answers. I will tell you, just last week, Patrick there, his webinar on ceramics was absolutely phenomenal. Probably one of the best webinars that I've heard in a long time. So if you have a chance, I would go back and listen to that one. So just a couple of disclaimers. I am a KOL for NuSmile and Dental High Tech, which means I do get compensated for being here tonight. I will tell you that I put a lot of time and effort into these webinars, and I don't do this to make an income. I do this because it allows me to really understand these products. When I work with other doctors, I get a chance to not only be helpful to other docs, but also to really understand these devices myself. So the topics we're going to go over tonight, we're going to go over just some basics about both devices because only about half of you actually own one of these right now. Then what we've tried to do is every single webinar, we've gone back for the last few months, both on Facebook and phone calls and emails, and tried to pick the questions that people had the most or the things that they're struggling with. Because I will find if one person has a question and they're reaching out to Aaron, say, Aaron, I can't get my pedal to communicate. It's not just one person that's having that problem. These are easy things to fix, right? None of these questions or concerns from doctors have been, something where we couldn't just, hop on a phone call or hop on a Zoom and help you. But it's good to have this kind of body of knowledge now. We have enough doctors using these units. We should be able to answer all your major questions, hopefully tonight. One of the most important things I can do for you, I think, is to go over, we call it the 4 Ps. And this is this little mantra that I say in my head every single time, from the second I walk into the room to when I finish giving that injection. And it just makes sure that I am remembering all the steps. For example, I don't want to start with step 1 and try to deliver those couple of drops of local anesthesia to get blanching and then realize, well, my unit isn't on. It's happened to me before. And so that's why I've come up with this mantra, and I do say it in my head every single time. We'll talk a little bit about local anesthesia chemistry. We'll talk about positioning. And then really what I want to spend a fair amount of time tonight too is just going over example cases, because some of you, when we have doctors that ask about access, they ask about how much local anesthetic we give or what anesthetic we give. That's really best described as we go through these cases. So why do we do this? And why do I think that the administration of local anesthesia via the intraosseous delivery method really should be the standard of care for any pediatric dentist? I'm careful when I say painless, because no matter what, I don't care what unit or what procedure you're using or what device, we can't guarantee that our parents that the child isn't experiencing anything, any type of pain or anything that's uncomfortable. For example, I was talking to a doctor last night and she was saying, well, sometimes she's given, step 1 and she's done her manual bone penetration, and after maybe a third of the carpal that she's given, the patient will react. Well, what the patient's feeling there is just pressure. We know that in that cortical bone, they're not pain receptors, just pressure receptors. So again, I'm careful about saying pain-free, but I will tell you that in my experience, now that I really feel like I have mastered these units, I'm still learning every single day, but I will tell you that 8 out of 10 or 9 out of 10 times, when I'm using these units, I don't have pain. Right now, I may have a patient react, they may feel a little pressure, but if I follow all the steps and I follow the rules and all these things that we go over with you tonight, I will tell you that it's not just my experience, but all the other KOLs and all the other experienced users find that most patients don't even react. My goal is to be able to give local and the patient didn't even know. And the parent is just staring at me. And sometimes the parent has a lot of worry in their face, and you can see as soon as you take that needle out, you put it down, and the parent just relaxes, because for them, what they may remember about being a child is not only having the pinch from the local, but having the numb lift afterwards. And let me tell you, not having a single numb lip in your office for 10 months or so is it's really an amazing thing. So that pain-free experience or painless experience we can give to our patients, that's where the magic. And we have to find out, again, is this pain or is this pressure? We don't have to give supplemental lingual palatal injections. What really sold me on this was I had a patient that was referred to my office, 10-year-old, needed number 3 out, very infected. This was early in my journey with these units, and I gave 1 intraosseous injection on the mesial tooth number 3. And I said, okay, I'm going to jump in and I'm going to believe that the patient is truly numb. And I gave almost a full carp right next to number 3 in the mesial, and they literally did not feel the injection. They may felt a tiny bit of pressure. I was taking out number 3. but amazing cooperation. And from there, I knew that this is what I needed to do for all my patients. And truly, if you're delivering intraosseous local anesthesia and you're truly in that cortical bone, you do not need to give a supplemental palatal injection. Okay. Not having lip bites, not having cheek bites. Let me tell you, I haven't had one since I've been using these units, and it can be scary for parents, right? I mean, we know as practitioners that when this happens, it looks bad, but child's fine. I don't think I've ever had one that's gotten infected, but they don't look very good, and sometimes it takes days and days for symptoms to resolve. And now I can tell parents, nope, they can eat and drink right away. Now, if I'm cementing a crown or something else, I may have the weight, but I do not have this issue with collateral numbness. If you're using this method and you do have some collateral numbness, please reach out to us. There's some reasons why, and we can walk you through that. We can do bilateral mandibular treatments without an issue. And typically what I'll do in my practice, before this is I'm splitting up, right side, left side. You don't have to do that anymore. The other nice thing is if I think that child's only going to be cooperative to do one quadrant, if we have extra time and they're still cooperative, I can go ahead and do the contralateral side. And doing that just over a couple months, and these units have paid for themselves in my practice. And fewer appointments. All of us know what overheads are like in dentistry right now in our practices. And anytime that we can, condense these down to one visit instead of two visits, parents happy, we're happy, our office managers are happy, and everybody's in a good mood. When we say immediate action, it truly is immediate action. If you're truly delivering that your intraosseous local anesthetic at the correct amount in the correct areas, you should be able to take that needle out and start right away. I didn't believe it at first, but after doing this for a couple of weeks and being able to start treatment immediately, it's a complete game changer. And we can start anesthesia and just start working right away. Definitely better behavior management, less stress for me, less stress for the patient. I don't think I really realized how stressful, crying is for staff as practitioners. We're just used to it, but especially new staff, they don't do well. It's just human nature not to, to be stressed out when you hear a child cry. And anytime I can decrease the amount of crying in my practice, I'm happy, right? And as a practice builder, there is nothing better than not hurting a child in your office. And the case that really sold me was that this patient was referred to me for extraction of those lower four anteriors. And I'll talk about this in a minute. That was my watershed moment of saying, you know what, I'm never going to use a standard syringe again. Case in point, we do not have collateral numbness. Now, if you are finding, and some of you have reached out to us and said, I am getting a numb lip. It's usually not a numb tongue. It's usually a numb lip. And the reason for this is in that first stage, if you're delivering too much local, you will have an issue sometimes of collateral numbness. Remember, all we're trying to do is just provide blanching and local anesthetic right at that papillary triangle. So I think about 4 millimeters, diameter of numbness from the tip of my needle. That's all you need. If you're finding that you're seeing blanching down in the vestibule, there's a higher chance that you're going to have this collateral numbness. And what it means is you're likely dumping all that local anesthetic into the soft tissue and that you're superior to the cortical plate. So we've got to work on, getting your positioning correct. I highly encourage all of you, if you're having the same issue more than once, ask parental permission to film and grab an iPhone, have one of your assistants take, short video, 30 seconds a minute. The next time you're going to do that same procedure they're having an issue with, it's much easier for one of us, Jordan or Chris or Aaron or myself or any of the KOLs, just to send us a video instead of trying to describe what happened with the patient. Onboarding. I highly encourage all of you, and you know who you are out there, that you have asked one of your staff members to do the onboarding for you. There's a reason why we want you as clinicians to do the onboarding. The training is excellent and it really is required. Take the time to understand how to use these devices as a beginner, and then come join webinars like this and we'll teach you how to do, understand all of the nuances to be able to call yourself a master of this procedure, but you really need to do the onboarding yourself. If you don't know how to get on here, if one of your staff members did it for you, and won't, it happens sometimes, just reach out to us. Reach out to Aaron or Jordan or Chris, and they can help you with credentials. And there's more help on all of these procedures than you could even ask for. And you will receive the free box of needles there. So thank you very much. These handouts are newish as of the last 2 months. And what I love here is it wasn't just NuSmile, something their advertising department wrote these. This was a combination of many of the KOLs. And we sent in some of the information that we wanted parents to know. And it was all collated together. You can buy these from NuSmile. One suggestion I have is, after a while, it gets kind of old having to explain this to every single parent, is have them in your operatories, right? We have them just hanging in the operatory there in a little holder. And I know what some dentists do is they actually attach, if they have a little card or something about a new patient program or having referrals, it's a nice little thing. I don't like to be too pushy, but something you may want to attach to that and have it available for parents. As I mentioned, there is more help than you guys could ever need or ask for. So you reach out to myself, you reach out to Chris, to Jordan, to Aaron, and we will help you or your teams in anything you need. I highly encourage, if all of you are not part of the Facebook group yet, please join. You can join even if you don't have about a unit. We do ask that if you have questions or concerns, please post it on Facebook in this group and not an IPEDO or other groups, because you may just not get the answers that you need right away. And if people aren't familiar with this, it may be something that you're having a user error on, and it's not a problem with the unit. We really want to try to promote these units as a standard of care. So there's a lot of pieces and parts to becoming a master of these devices. The basic training is important, but what I really want everyone to understand is kind of the banal minutia of this, of, how do we effectively give injections in every single quadrant? What anesthetics we use, how much of that anesthetic that we're using, and we're going to go over all those things tonight. So let's back up a little bit and just talk about the basics, okay? One thing I think is key for all you to understand that are new is this is not that much different than what you were doing before. I never really realized it. It's funny, but we were always giving an injection, an infiltration that at some point turned out to be intraosseous, right? So when we gave our standard infiltration here, what we were waiting for is for that fluid, for that local anesthetic to perfuse through the bone, right? So no matter what, you were always giving an intraosseous injection. It was just that you were injecting that local anesthetic superior to the cortical plate, and you were waiting time for it to pass through the plate, through the cortical bone, down to the apex of the tooth. What happens with that is, number one, it takes longer. And number two, you need a much higher volume of local anesthetic. Now I can't even wrap my head around giving a block to a 5-year-old. To me, it almost seems like you're trying to numb a finger, but instead of numbing the finger, you're going to numb at the elbow. It just doesn't make sense anymore. And I will tell you that all of us that have adopted this as their primary method of delivering local anesthetic, this is just what we do. I mean, I could not even wrap my head around using a standard syringe for most patients now. So when we gave a standard infiltration, what was occurring was we were injecting through the soft tissue superior to the cortical plate. That local anesthetic needed time to move through the Volkmann and conversion canals and then get past through the cortical plate and through the cortical bone down to the apex of the tooth. So all we're doing that's different with this method of local anesthesia is we're skipping that cortical plate. We're taking that velvet rope off to get in the nightclub restaurant right away, and we're delivering targeted anesthesia. And that term, I didn't make that one up. I learned that from a colleague, and I really find that that's an important point, is this is targeted delivery of local anesthetic. Where do we need this, right? We need it at the apex. So it doesn't make sense if we give this as a regional block far away from the tooth. The local anesthetic needs to go near the apex. If we give it near the apex, the tooth's going to be numb right away, and we use a much, much smaller volume. This is where we need to deliver our anesthetic. Now, Our intraosseous methodology is simple. We are going to pass that needle through the periosteum, past the Volkmann and eversion canals, and we're going to be giving right into that cortical bone. We're skipping this whole area and that's how one of the reasons why this is instantaneous, right? We're giving that fluid literally almost near the apex, and we need far less local anesthetic because all we're trying to do is fill that vessel, fill the cortical bone, and get that local down to the apex as fast as and as close as we can. So for those of you that are new and you haven't seen this, I just want to at least show you this this quick video. So these are the general steps in giving intraosseous injections. So the number one here is we're giving just a small bolus of local anesthetic at the papillary triangle. So that white area there is, I've considered about a 4 millimeter diameter area of numbing. And then we're changing our angulation for a manual bone penetration. So we're actually pressing that needle through the cortical plate. Now, this unit looks a little different. This is a unit that's available in Europe. We don't have those here in the United States. But once we pass that cortical plate, we're going to be passing the interseptal bone and delivering into the base of that cortex of bone as close as the apex as possible. This diagram is actually very important because it shows us the difference between interseptal bone and the cancellous bone in the body of the mandible. And that's an important distinction. We'll talk about that later tonight. So what are the three stages? All of you that are familiar with these units, you'll know this already. Number one is that mucosal periosteal anesthesia. All we're doing is giving a minimal amount of local anesthetic, a bolus that's small enough just to numb the papillary triangle. I find that it's going to be 5 to 10 seconds. That's about as long as it's going to take for this first stage. It's not a measure of time that's important. It's looking for that, having that circular area of blanching. That's always our check step. If I have a tissue that's blanched, I know that I'm not going to have a problem with patients feeling that step number two. Now, again, blanching, I only want to see it in the papillary triangle. If you have blanching all the way down to your vestibule, number one, you're not delivering intraosseously, and number two, you've got a pretty high chance of having collateral lip numbness. If you did have collateral lip numbness, it's not a big deal, but it may mean that you did not give an intraosseous injection. Okay. So that first stage is just that initial delivery, 5 to 10 seconds. Then number two is our manual bone penetration. This portion is going to be important later on when we talk about delivering local anesthetic to older patients. There's been some posts about people having difficulty with older patients or pain with older patients, and that's a distinction that I want to bring up tonight, is that these units are designed for MBP, manual bone penetration. We're actually physically using force to drive that needle through the cortical plate. If you have a patient that's older, that becomes more difficult, and we'll talk about the detail later. And then step number three is our delivery of our anesthetic solution. Paul Bond shot this video. I think it's one of the best that we have. The one caveat that we have here for those of you that are not new is you see that he's holding his sew-in this, in this example, he's not holding it at the base of the hub there. And that's just to shoot the video so you can see. But let's go through this and you can see the three steps of delivering local anesthetic. So step one is our initial penetration of the needle. We're at about 15 degrees, and you can see just in that papillary triangle that we're looking for blanching. Again, 5 to 10 seconds. It's really not the amount of local that we're giving. It's looking for how much blanching do we have. And I really want to see, a fair amount of blanching there in the buccal. If I don't have blanching, I'm not sure that the patient is actually numb in that area, and I'm careful not to jump to the next step. Now we're going to switch our positions. I want you to observe how he's holding the syringe at this point. He's right close to the hub. We're going to push, and there we go. That little resistance, and that's our manual bone penetration. We're switching now the pedal, and now we're on the large pedal. And at this point, we're delivering our local anesthetic. Depending on what procedure you're doing, depending on how many teeth you need to have numb, depending on the age of the patient is going to dictate what type of local that we're using and how much we use. And I'm going to give you some general guidelines tonight on which local anesthetic to use and how much of that local to give. And, depending on if you're going to give a quarter carp or half carp, 3/4, that's going to be dependent on how long this takes. We do want to, as soon as you're ready to finish giving that bolus of local anesthetic and you come off the pedal, I encourage you to wait a few seconds. There's going to be back pressure, right? So if you pull the needle out right away, you are likely to have some fluid come out there, some local, and the patient can taste that. If you notice, his isolite is in place. So if you're using an isolite, I do encourage you to put that isolite in first. Not everybody does that because you're used to giving, maybe having a standard mouth prop, giving local, and then going to your isolite. But isolite's a great way of making sure that they don't have any bad tastes. If I can give you one piece of advice about taste, is what we keep in all our operatories are little xylitol wipes. The xylitol wipe, the nice thing, we use those when we counsel parents about at least wiping off the teeth after breastfeeding at night. But the nice thing is that if your patient does have a bad taste, we open one of those xylitol wipes, we clear off their tongue, and that can make all the difference in the world. I want everyone to really look at that needle, all right? We had questions that were proposed in the Facebook group, and I've received a couple phone calls the last couple weeks, and the doctors were worried about doing some type of damage to the subcutaneous tooth. This is a 9mm needle. And this 9mm needle is not going to be anywhere close. If you're positioning it properly, you're not anywhere close to that developing permanent tooth. So please don't worry about that, okay? In order to be able to give this an injection that is really, we call it a perfect injection, it's going to be knowing how much local, the right quantity, taking your time and getting close to the target. And again, for this, you've got to use an electronic device for this. If you're trying to do this by hand, it's not going to work for many reasons. But if you don't deliver slowly, drop by drop, we're going to have an issue with perfusion, and that local is going to spread too far from our intended target, and we won't have proper delivery. One thing we need to remember is that in this diagram, and many of you saw this on the initial onboarding, and what this describes is the number of teeth that'll be numb in a quadrant. We know in the maxilla it has an omnidirectional flow of blood. So typically, here on permanent teeth, we're going to see 2 teeth distal and 2 teeth mesial. On the lower arch, where there's a unilateral bias of flow, we're going to have 1 tooth distal and 2 to 3 teeth mesial. The point that I want to make here is this is osteocentral delivery of local anesthetic. If you use a 16mm needle, which we typically don't with this because I've tried it and it's easy to bend a needle. Vast majority of the time we're using a 9mm. It is difficult for teens to truly get osteocentral local anesthetic. So if this is a 9mm in a full permanent dentition, I can guarantee you that both teeth on the side of your injection site will be numb. If you can get this many teeth numb, on the lower 1 distal, 2 to 3 mesial, and then 2 and 2 in the upper, if you can get that with teenagers, great. I find in my hands, really what I'm relying on is 1 tooth mesial, 1 tooth distal. Okay. Now, the most common quadrant that most of us start that are right-handed is giving our pediatric, basically what we used to give as a block. Now, for children with a 9mm needle, we're going to 100% have success with 1 tooth distal and 2 teeth mesial. All right. I find that I will also, if I have the 6, I may not get pulpal anesthesia here, but for a class 2, class 1, usually I will get numb. If I'm worried about it, I may give part of that carpule on the mesial of the E and then on the distal. So for those of you that have these units already, you already know this. But the Sew-In and Sleeper one, the difference is only in the one is wireless and one's not. These are the current pricing. And if you have questions on this, it's something you'll reach out to NuSmile directly. If you're only going to buy 1 unit and move it from operatory to operatory, you're going to buy the Sew-In. I personally have both. And I think there's advantages. I actually like the feel of the Sleeper one a little bit better. I like the weight of it. The other thing that I like about it is that the light is circumferential. I can see the entire unit. The pedal on both units is similar. The only thing I want to talk about tonight and just really quickly show you is some of the most common settings here, okay? Remember that for your SOAN, there's two modes as far as your injection speed. The way that I remember it is B for bone. If you're giving an intraosseous injection, you need to have this on low. When I've trained other dentists or I've seen, my associates, once in a while I'll walk by at the beginning and I'll see the modes in pink. I will tell you that for intraosseous delivery, they're going to feel that, right? I've had times where, I accidentally hit the button and it was on pink. And patients felt that difference in pressure. So you really need to make sure that this is on blue. If you're using the 16 millimeter needle and giving a block, I don't think I've ever done that with these units, but it does have that button on the upper left that you can do some aspiration. You just need to make sure you've already given an eighth of a carpule, okay? Please make sure that when you're stepping on the pedal, you're really centered here. There can be times, and some docs have told us, well, they stepped in the pedal and nothing happened. It may have been because you heard the click because you were stepping on the side of the pedal and it actually didn't get fully depressed. As far as options go, the only ones that I want to talk about right now are cruise and drive. The difference here is that in cruise mode, you're going to press the pedal once to start and then again to stop it. There's going to be defined level of how much local you're going to give. And you can set that as an option, either quarter carb, half carb, 3/4, or full. It really is up to the doctor. I've always kept my units in drive mode. That way I have control. That's really up to you. And you can change these. Just make sure when you hit that triangle, you don't hold it down because that will retract when you're trying to do these settings. Speed-wise, there are some different options as far as the speed profile. I would not change those. I would just leave them as is. And my unit is on blue for low basically all the time. The SOAN does have the ability to give a block or to give an infiltration. That's when you're going to be in pink. The one time that I do have this in pink, and I'll talk about this here in just a minute, is for exfoliating primary teeth. I don't give IO for that. Typically, if there's no roots left, I'm going to put it in pink and just give drop by drop and get soft tissue local anesthetic. Okay. Sleeper one, it does have the 3 different lights. I don't want to spend too much time on this. Most of you have the SOAN, but as I said, I love this unit. I've got one, and I have it actually built into my operatory like this. So that power cord is built into my ADEC unit. So it's all nice and tucked away. Let's talk about the top 10 questions or concerns that we've gotten over the last month. Number one, and I think this is the most important slide for tonight, is this is the 4 Ps. This is the mantra that I say every time I'm going to give an injection. Number one, when I sit down, I want to make sure the unit is on. It happens to me from time to time. If I don't pay attention, I go to give stage 1 and then I look down and the unit's not on. It's not great because then you've got to go back in the mouth. You've actually got to turn it on. Okay. So I come into the room, I sit down, I'm in number 1, I'm going to make sure that unit's on. If it's been sitting, that the unit may switch to turning itself off. The times there are set. You can actually change the times. I just keep whatever standard. Then number 2 is I'm going to review the radiograph. You need to look at a radiograph for every single one of these injections, looking at your site, if there's bone there, if there's not, if there's presence of infection, if there are teeth in the way, and then tell shall do with the patient, and then anything I need to talk with the parent. Then number 3, is the pedal there in the correct location? There are times where we're working with a patient and we're concentrating on step 1 and step 2, but we forget that we can't see the pedal. The pedal's across, it's on the other side of the chair. And I will tell you, if you think that you can hold your right hand, if you're right-handed still, and try to grab the pedal with your foot and move it, it doesn't happen. You're going to wind up advancing that needle in a location that's not so comfortable. So please, before you do your very first step, make sure your pedal is there. One issue that we've had with some doctors, they said, I've stepped on the pedal. I'm sure my foot is centered, but it's not communicating with the unit itself. It works by radio waves, so there's not a battery in this. And what we think is happening is some of these big, like in my office, like these big ADEC chairs, and it's just not getting a signal all the way through this chair, right? There's a lot of metal and plastic there. So you may want to have your pedal just to the side. And then we want to make sure that our positioning is correct. All right. This is a big one. I've had a few kids that start complaining of pain when they're actually checking out, and the kids were fine during the procedure. My theory on this is we need to remember that the working time for intraosseous local anesthesia is less than a standard block. Okay, so for the 1 to 200,000, we're getting about 30 to 45 minutes, and for 1 to 100,000, it's a little extended after 45 to 60 minutes. My theory is these patients were always having pain, but it was geographic success. They were either in the car on the way home or they were at school, and then things were starting to bother them. So just remember that your working time is shorter on this, and I see that as a good thing. One of the things you may want to consider doing is giving and I've done this more and more now, is either at the beginning of the appointment or asking parents to give Motrin or Tylenol to that child ahead of time, and then everybody's happy, right? This is one that recently came up. There were some docs asking questions about why is, number one, for my older patients, 14 to 17, why am I not able to penetrate to the bone? And then for those that do penetrate to the bone, why am I having pain? The thing that we need to remember is the difference between interseptal bone and osteocentral bone. Okay, these are only 9 millimeter needles. We're not using a 16. And when you deliver with a 9 millimeter needle on a patient that's in a full permanent dentition, you are not likely getting osteocentral delivery of your local anesthetic. You're numbing just this interseptal bone. What happens is we know that in that area, it's not the same blood supply, and you're going to have an issue with how many teeth you can get numb. Anybody 14 and older that I can deliver an interosseous injection with, I consider it a bonus. I'm pretty much 99% patients under 14, I can deliver osteocentral local anesthetic, and I can profoundly numb that entire quadrant. But for teens, just know that you may have a harder time getting through. You can get through, even 17, 18-year-olds, sometimes adults, but they do have thicker plates, especially if they have larger patients. The bone is just thicker, especially in the mandible as we move posteriorly. All right. And again, the other important thing to note here is if with teenagers, full permanent dentition, I really only want you using 4% septo with 1 to 200,000 epinephrine. The reason being is if you're using 1 to 100,000, you deliver a large volume into the papilla, there's a little higher chance that you could have some necrosis there. I've only seen that. I haven't seen it in my patients. I've seen a couple photos of it before, but it's just like if you were to numb your fingertip, right? There's just not great blood supply there, and you can have a higher incidence of pain or necrosis of soft tissue afterwards. Again, there's that difference between interseptal delivery of local anesthetic versus giving osteocentral, right? As far as volume goes, for most patients, if I have a patient, let's say that's 10 and under, I find in any quadrant the most I'm going to give is a half-a-carb. If you have an area you're giving multiple sites, there's an infection there, you may be giving more than that, but a very few and far between am I ever giving more than a half a carpula of anesthetic. Some people worry about they don't hear the pop. You are not, just because you don't feel a pop or hear a pop doesn't mean that you're not past the cortical plate. Okay, I will tell you that 10 and under, you may not even feel much of resistance because the plate is so thin. 10 and above, you're usually going to feel a pop there. As we know, the more apical you go, the thicker the bone is. And for those older patients, and you're trying to manually penetrate through, it can be a couple millimeters of bone. And so don't expect, 14 and up, it's not a loss if you can't, get through the cortical plate. It just may not be possible with manual bone penetration, okay? Younger patients should not be an issue whatsoever. When we use other devices, a generation ago, we're actually drilling through the bone, like with this X-tip, you could give an intraosseous injection on anybody. But one of the beautiful things is, and these units are so easy because we're just able to penetrate through the bone. This is a big one. Palatal access. Thank you so much, my good friend, Dr. Eric Hans, for reminding me and teaching me about this, is if you are right-handed, especially on the upper left-hand side, give palatal access. It doesn't hurt any more than giving in the buccal. We're just so programmed to not give an injection on the palate. And I said, don't be a baby. Just do it. You're going to be a little worried the first couple times, but I promise you, I have never found that there's more sensation on the palate. And you remember, there's only two roots that you're worrying about there, your adjacent teeth. It's not like on the buccal where you've got multiple roots and you have more anatomy in the area. So vast majority of the time, since I'm right-handed, I've got a numb I&J, I'm going to give palatal delivery, and their patients are going to be fine. Especially, we know that most infections will drain towards the buccal. I don't even think twice. Give it on the palate. All right. Your units, you want to make sure that your staff doesn't tighten these too tight. We've had a couple docs tell us, well, the silver ring on their sew-in came loose. It is because their staff is over tightening the cartridges. If you're having pain while delivering the first stage, it's usually because you're advancing the needle too far distally. So in this case, where we're going to numb between S and T, I want you to think about that triangle, cut it in half, but don't enter in the middle there. If you enter in the middle and you advance a little bit, you're actually going to get close to the PDL and the adjacent tooth. So you want to be 1 to 2 millimeters mesial to the center to give your initial stage 1, and then you can switch when you give your stage 3, then you're going to go straight in the middle of that papilla. Remember that we only want to be in about a 15-degree access. Anything more than that, and you can bump into the periosteum before they're numb, and that's not going to feel nice. Just remember with your lights that it's normal to see some lights. We've had a couple doctors, call in saying, "Oh, I'm worried I have 2 lights." Go back to your manual. It's very normal to have 2 or 3 lights there. But if you have 4 lights and it's ongoing, the unit actually will retract the plunger. It will keep you safe. I want to move forward here just for a second. We talked about the pedal. If it's not responding, just move your pedal to the side a little bit. It's likely just because it's getting some radio interference there with your chair. Over-the-counter pain medication, it's something I just do routinely now. I think it makes the parent feel a little bit better when there's Motrin or Tylenol on board, and that's sometimes the most important thing. When you store your devices, you can see this is actually what you don't want to do with your Sleeper One. If you have a carpule that's loaded or with your sew-in, it is possible that you could have some leakage here, and in that local can go into the electronics of your unit. So don't leave it on the units like this. When we have this loaded on our Sleeper One, we have it actually facing down. It's opposite. I shot this today, and I think this is important to see. So this is under the microscope. I use surgical microscopes in my main operatories. And we had a doctor that called in, I think last week, and they were saying, I'm just having a problem with, I can get the first quadrant, manual bone penetration, no problem. When I go to the second quadrant, it's not as easy. And that's an easy answer. You've got to change your needles. Okay. So what I did here is I took, under the scope, I took a photo of a needle right out of the box. Then I actually just went to a cardboard box and popped through a couple times. And you can see how easily the tip of that needle bends. These are so sharp, and that's why patients don't feel that first stage, that it'll cause a little barb, right? And that's actually not with much pressure. That was a couple times through a cardboard box, right? That end of your needle is so thin and so sharp that you'll have that little barb, and it's much harder to get through. So my general rule is if I can't pass through the bone in an area where I think I should be able to, I'm going to take the needle off. It's 20 odd cents. Just put a new needle on. The more that you try to have manual bone penetration with a needle that's bent, the more pain you're going to have afterwards. And you see that little barb, actually, when I was doing this, I felt it with my finger. It's pretty blunt there. All right. As far as placement goes, if you're right-handed, the right side is often easier. Remember, you can give buccal, you can give palatal. Thank you, Paul Bond, for these photos. And you're going to be fine either way, right? For some people, giving palatal on the same side that they're working is a little bit more difficult. So I typically, because I'm right-handed, for AB, I'm going to give on the buccal. For IJ, I'm going to give palatal. I do the same thing every single time. The anterior, really no different than the posterior as far as positioning goes. Just remember, we need to look at root access and root alignment. Sometimes we have ectopic teeth and there could be a root in the way. So got to look at our radiographs every single time. Upper left, it's up to you. Again, sew in your sleeper one in place. I just find it keeps the tongue out of the way. It keeps it from having any bad taste. If you're using it, go ahead and put it in right away. Lower left, again, same access. Buccal, lingual, does not matter. If there is an infection on the buccal, give it palatal. You'll be fine. It'll pop through as easy, I find. And we've got to make sure we're looking at those radiographs every single time that there's not an active infection. Let's quickly talk about which anesthetics we use. Really what we teach is just using 4% Septicane. Septicane's been in the US since the 80s. The distinction is, do we give 200 or 100, 1 to 100,000 concentration of epinephrine? I'll make it very easy. Vast majority of the time, 90% of the time, I'm using 1 to 200. The only time that I'm using 1 to 100,000 in my practice is if there's active infection, number one. Number two is if I want to have I want to have a prolonged effect. Or number three, if I have a feel, if I'm worried about, a hot tooth, if I'm concerned at all, and I really want to have as much of that fluid stay in one area, I'm going to use the 1 to 100,000. Again, for teens, please, please, please use the 1 to 200,000. But my staff knows if it's an extraction, vast majority extraction, or an infected tooth, I'm using 1 to 100,000. If not, use the 1 to 200,000. I have a star here on avoid under children under 4 years of age. We won't go into that, but I will tell you is that all of us that do this are using Articaine with children and that are less than 4. If you listen to any Malmed's lectures, he's going to tell you the only reason why it has that warning is for the fact that they just couldn't get a bunch of parents to sign up to test their children with Septicane. I would encourage all of you to start on the lower right. That's where most of us start if you're right-handed. Again, 1 tooth distal, 2 teeth mesial. We talked about getting into that papillary triangle and starting just slightly lateral. You saw this video. For those of you that are new to this, I would also show this to your staffs so they get used to. So for them, this may be new. I watched this. This is by far my favorite video. It really goes through the process. Just remember that on the upper arch, it's going to be the same thing. Now, here in this angulation, Paul's using this vertically. I tend to come horizontally. The only thing you need to be careful here is if you're going to give a vertical delivery like this, it's easy to advance a little bit too far. I would not do this from the start. I like to give it horizontally. And I think, Aaron, that's typically what you're teaching, right, is coming from a horizontal access. Just be careful here because it is a little easier to slip and wind up bumping into the periosteum. For the anterior, this is where if I could only have this unit for one thing, it's going to be for to give anterior local anesthesia. This is the case that sold me. Normally, if I needed to extract all 4 of these incisors, I would be giving multiple injections. And this patient, they were about 7 or 8 years of age. It's 1 intraosseous injection. So I gave stage 1 there between O and P, half a carp of 1 to 100,000 Septicane, and all 4 of these teeth, that was it, just that 1 injection, and all 4 of these teeth were removed. Patient did not move. When you're giving in the max anterior, the one thing we need to kind of be careful with is when you have a lot of soft tissue that's in the way, we see a lot of patients that have these thick frenums, so you may need to give slightly lateral to that, okay? Case in point here. The more soft tissue that you're injecting through, it is possible that you're going to have soft tissue that's going to plug up your needle. So I try to go slightly lateral to the frenum there. And you can profoundly, that single injection, I know from canine to canine that patient's going to be numb. Now, I do want to make sure that I've got profound blanching. That's one area in the anterior. That's my check step. If I don't have profound blanching, I'm going to need to probably give more local or make sure that I was in the right area. But I a number of times where I've, pulps and crowns on all 4 anterior teeth, or I'm taking L4 or pulps and crowns on all 4 anterior teeth, and I'm doing, composites on the canines, and they're profoundly numb from that 1 injection. And again, 1 to 200,000 most of the time in this area, unless I'm doing extractions, then I'm going to go to the 1 to 100,000. This came up actually last night in a conversation. If you have an over-retained tooth, this is one example of where I'm still going to use a 9 millimeter needle. I'm not going to give an intraosseous injection here. You don't need it. So I will just give that stage one, and I may advance underneath the tooth, or I may come more horizontal and advance almost to the lingual and make sure that I have blanching circumferentially around that area. But still, you can still use your sleeper one or SOAN with that 9 millimeter needle. You just don't need to give intraosseous injection here. And actually, I find sometimes for some reason for teeth like this, if I give intraosseous, sometimes I don't feel like I get profound soft tissue numbing. It's not the case all the time. That may just be patient specific. But if there's no roots on here, there's no worry that you need to give an intraosseous injection. Remember that you need to look at your radiographs to see where that bone is. Okay, if in fact you have an infection there, if there's a partilus, if there's not organized bone, let's say you take your radiograph here and you see there's infection from the D or around the D, you're going to want to go ahead and give an alternate site, and that would be the lingual of the E. If you have a sinus tract like this, you may need to give your local anesthetic on the lingual aspect there, on the palatal aspect. If you have large infection in an area, I may give it 2 different sites and split it up. It's absolutely fine. But if you notice, where you have perilucency or an apical lucency at the furcation, that's not organized bone, and it is sometimes harder to get numb in those areas. So you may need to pick an alternate site. Same thing like here, large, periapical radiolucency. You may need to switch sites, and sometimes I'll give 1 injection from the buccal and 1 from the palate or 1 from the lingual if I'm a little worried about making sure that I have profuse local anesthetic heading through the bone. All right. Got to look at our radiographs. If you have ectopic teeth, you may need to move your needle to one side or the other. You may be leaning slightly mesial, slightly distal. Now, again, 9 millimeter needle, usually not the case, but we need to make sure every single time that we're looking at our radiographs. For those adult patients, you remember, if it's a full adult dentition with a 9 millimeter needle, you most of the time, you're only going to be able to give an interseptal injection. Choosing your site is something I want you to do. When you're new, maybe sit down the night before, decide where you're going to give that local, write it down. One of the most effective uses of delivery of intraosseous local anesthesia is for these hypoplastic teeth. I treat a lot of these teeth in my practice, and I'm batting 1,000 as far as being able to have profuse and profound anesthesia here. That was not always the case. I'd give a block, I'd give an infiltration, I'd come back 20 minutes later, and sometimes you could not get these patients numb. And I literally have not had one, I guess it's possible, but I have not had one patient in the large volume that I see with hypoplastic MIH teeth like this where there was an issue. One last comment. If there's a sinus tract, if there's a partilus that's already under a lot of pressure, that may not be an area where you want to inject close to. So you need to pick an alternate site, or you may give an infiltration here. Remember, if you're going to give an infiltration, you may want to switch to the next mode, which is the pink on your sleeper one. We've covered most of these questions already tonight, so I'm going to skip through these because we've answered them already. I do want to, let me go forward. I encourage all of you, if you have questions, I know we went through a lot of material in a short period of time. This hour goes quickly. Reach out to us if you have questions. As a reminder, videotape, I'm gonna show my age. Take your iPhone out. Don't use a videotape. Take your phone out, have your staff record if you're having issues. We'll review it. I tell you, if you post on the Facebook group, you will get more answers than you probably want. People are just clamoring to answer your questions and to help you. If you're coming to the APD, we're going to be there. Most of the local large meetings, I know I'll be in South Carolina at the end of the week. We're going to be there. So we really try to deliver as much information as possible to all of you. And I appreciate your time tonight. And I'm going to turn you back over to Jordan and Aaron.
Awesome. Thank you so much, Dr. Solomon. So we'll get into Q&A. Just a reminder, everyone, please put your questions in the Q&A function. Aaron, do you want to rattle off the Q&A today?
Sure. So far, we only have one question, but y'all send them out because this is your time to ask. Dr. Solomon's here. We're here. So if you have any questions, even if it's about, not the mastering stuff, like earlier stuff, we're willing to answer it because you still got some time left. So the first question is from Dr. Contreras, and I remember meeting you. Hi, Dr. Contreras. Are there any effects on the bone in these pediatric patients under 12?
Like deleterious effects to the bone? No, not that I'm aware of. No. This is, of course, like the hematologist, you want to talk to them ahead of time, but all the hemo consults that I've had, not a problem giving intraosseous local anesthetic. I suppose the only issue that you could possibly have is if you're using one to 100,000 and you're giving to a high volume and it's interseptal. I think that's one area that you could possibly have some transient necrosis in the area. Now that's no different than giving an infiltration sometimes, but that's really the only thing. If I was going to worry about something, it's my older patients, and older I mean kind of 14 and above, giving higher volume of local anesthetic with the 1 to 100,000 in the septum. I haven't had it happen to me, but I've seen some photos of some kind of notching in the tissue or pain there. Patient's fine after a week, but that's the only problem that I'm aware of. And in the collective, I don't think we've in literature it's not been an issue. The thing we need to remember here is these units are newish to us, newish by less than 2 years. But in Europe and the Middle East, these have been in use for 15 years, right? So we're not new to the game.
Also, since we're kind of on that subject, could you touch on I know we've had a lot of questions just intermittently about, are you going to affect interrupting tooth bud?
Good question. One way you can answer that is go ahead and take your Soiner Sleeper 1. Step on either pedal, watch the drop-by-drop anesthetic, and just barely tweak your needle a bit. Push your needle a bit so there's some resistance. You're going to see those lights right away. There's a reason why that we don't want to use a woodpecker or some other device to deliver intraosseous local anesthesia for children. These are the only units that are available in the United States that are FDA cleared to give intraosseous local anesthetic. The SOIN is monitoring 1,000 times a minute of that pressure. It's not going to allow you to give pressure that's unsafe. If anything, I actually wish they would relax the safety profile a little bit so it doesn't, we're not going to do that. But if it senses that there is too much pressure or you're up against a piece of bone, it will not let you keep going. It'll actually retract the needle on you. Plus, remember, this is a 9mm needle, right? Even if you bumped into, the goal is not to bump into a tooth, but if you bumped into a tooth, you barely even touch the surface. Even if you had an ectopic permanent tooth underneath, you're not going to manually penetrate a tooth with a 9mm needle. Remember that 9mm, if you have 2 to 3 millimeters sticking out, you're only 6 millimeters in, right? That's not very much depth at all.
Perfect. Okay, Dr. Masai, a couple of times I have had patients come back with irritated inflamed papilla. Is this from too long of stage 1?
It may be too high of a volume. And the other issue is I don't necessarily think it's volume if you're only giving 5 to 10 seconds. Many of us, when we first start doing this, we're heavy-handed on the needle entry. And so if you don't split your papilla in half and give lateral to that central, midpoint, as you're injecting, it's easy to put too much pressure and inject to the PDL, the adjacent tooth. And I think that's usually where pain is happening from. So it's not the volume, it's where that you're giving it. And that's why we want to be, per se, mesial to that.
Next question is, do you ever have to bend the needle?
No, no, we don't. It's not like giving a block where sometimes, you bend the needle a little bit. I will tell you, the first couple weeks when I learned how to do this, I bent a ton of needles. That was not on purpose. If you hold the either Soit or Sleeper 1 right where the hub meets the cartridge, and you're giving pressure on the long axis of your unit, you will not bend needles. I can't tell you the last time I bent a needle, but at first you're going to bend needles. Don't worry about it. It is not going to break off. I mean, hypothetically, if it did, I would much rather have a 9mm needle that's sitting in bone break off than giving a block and have the pterygoid muscle suck it up. Worst comes to worst, if it did break, you grab a how and you pull the needle out. It's not going anywhere. If you're in bone, that needle is not going anywhere. But I have yet to have that happen to me, but I have bent a fair amount of needles. That will get much better over time.
As far as we know, we have not had needle breakage. We've had a few issues of maybe the hub separating, and that was from doctors admittedly going into different quadrants with the same needle. So basically they were screwing it in and unscrewing it and then going into the next quadrant and twisting it in and untwisting it, and they unscrewed the needle from the hub, and then it was sitting in the in the bone, but then you just pull it out.
Yeah. One of the issues we talked about the last webinar was a doctor had an issue with his cartridge actually breaking, and what we found out was he was just cold sterilizing them, and they're not meant to just sit in cold sterile. And the problem is it could have gone through cold sterile 100 times, but because it's not being autoclaved, you don't see any of the changes in the cartridge itself. So we have no idea how many times that was used. When you start to see, a little bit of cracking is okay, but when you start seeing, vertical cracks going through the unit, through the cartridge, it's time to replace them. And are they available? I know for a little bit they were on back order. Are they available now to get replacements?
Yes.
They are.
Yeah.
Thank you.
Hey,
you can just get them straight on the NuSmile website through your account, or reach out to me or Jordan, depending on who your account manager is. We're always willing to help you.
Typically what we quote.
Dr. Solomon, while we have you on the subject, can you walk us through your process of sterilizing the containers? Is there any?
So here's what I do. I go to the manual and I open the manual. And the manual says all the steps of what you or your staff is supposed to do. And then what you do is you do exactly what the manual says, and good things happen. If you don't follow the manual and you just do whatever you want, sometimes things don't work out. So I'm going to answer that with you all have access, you receive manuals, you can get the PDF very easily online. Let's print that out and put it in your sterilization area and follow the directions. How's that for a smart aleck answer?
That was great.
It's a good answer though, because the people at Dental High Tech, they're very thorough and they have tested it and they know what to do. So there's a reason that they put that manual out.
Correct.
Awesome. Well, if anyone has any more questions, please throw them in here while you have Dr. Solomon here to answer them live for you. And I was just going to mention earlier, you said there was more to come from NuSmile. So I can't say what, but me and Aaron were on a very, very exciting training that, we have more stuff in the pipeline. So if you are coming to future events, CSPD, AAPD, whatever it may be, please stop by the booth. And I think you'll see some really cool, new, exciting products from NuSmile that we'd love to, share with you guys.
Yeah, we're excited. This year.
Product. Can we mention the one product that we just learned about? No? Okay.
I don't think we're allowed to mention anything.
It's on the website.
You mentioned the CSPD. Actually, this year, Larry Johnson is the main speaker restorative, and then I follow up in 26 after her. So we're covering all our bases. I put my contact information up here again. Please reach out to us. If some of you have emailed me with ordering questions, I can't help you with that. I'm a pediatric dentist in private office, just like you guys. But technical questions, feel free to reach out to me directly. And I want to put up Chris and Aaron, all of these are the people in the know. So if you need something, you have a problem, they have a team of not just these people, but everybody at NuSmile is there to help you.